How are you?
I'm good.
All right. So welcome, Emily, all the way
Thanks for
from
having me.
New Orleans.
Yeah.
So tell me what company you're with, a little bit about your, because you're a pelvic floor specialist or a PT specialist.
Yeah.
Okay, cool.
So I'm a physical therapist. I work at NOLA Pelvic Health. We're also, I guess, better known as the Vagina Whisperer. My colleague and my mentor has a pretty significant following on Instagram. And so our website is actually the Vagina Whisperer, but our clinic name is NOLA Pelvic Health. And it's funny, I started out my career in sports and orthopedics. And I did that for almost 11 years. And I had my own 2 kids. I had a little bit of a traumatic second birth. And I was having some sort of residual physical limitations because of that. And I was introduced to my colleague. And I actually became her patient for a little while. And it just got me fascinated in the world of pelvic health and made me realize that unfortunately, in this country, we're still sort of at a disadvantage when it comes to that. And so it kind of ignited a fire in me to do that. And now that's what I do.
That's amazing. It's funny because I'm a relatively new mom, and I feel like once you kind of come in this mom world, so much, like, your views, your perspective, everything just changes.
Yep.
And that's obviously, but that's part of what made me want to do this podcast, because I felt like there's such a lacking of, like, this and she knows this, but there's no place where we as women come together to, like,
Correct.
empower and lift and talk and actually openly discuss.
Yeah. And I think, too, there's this massive disconnect, right? Like, we get so much information when we're pregnant. Don't eat this, do eat that. Avoid these things, or you can exercise, but here's what you have to do. And then it's like we have the baby and the guidance almost goes away overnight, right? And I feel like a lot of the things that commonly happen to women postpartum get dismissed as normalcy. And they're not necessarily normal. Just because it's common doesn't mean it's normal. And then also, some of the less common things just don't get talked about. And so then if it happens to a mom, she feels lost, she feels isolated, she might feel shame. And oftentimes moms really don't know where to go. So we get kind of both ends of the spectrum at our clinic, right? We do a lot of what we call childbirth prep sessions, which we offer virtual sessions for that and in-person sessions. But basically, it's bridging the gap from, okay, you're pregnant right now, this is how to care for your body. And then giving you information on how to prepare for delivery, whether you're having a vaginal delivery, cesarean delivery, unmedicated, medicated, birthing center, non-hospital setting. And then how to care for your body in the immediate postpartum phases. But then we also get women who had no idea that existed, and we see them after they've had a baby and maybe they're having difficulties or they had some trauma, or maybe that they just want sort of guidance on how to care for their body. And so, we kind of see all ends of the spectrum there. And then we even get some moms who are, decades past their last delivery and are still having issues and come to us really in a sense of desperation, I guess. They've tried other avenues and they just don't know where to turn anymore. And I think that is what we're missing the most, right? Like, there's just this huge disconnect in women's healthcare all across the board, right? Like, I think, we're doing women a disservice throughout pregnancy and delivery, and then we're also doing women a disservice as they age and they go through menopause and might potentially need a hysterectomy. So, there's a lot to unpack there.
So much. So I'm going to pick a couple of those things because there are so many things. What are some of the very normal or common things you see that, women might not address, but it should be? So things that, like, I know, for example, I hear women who say, like, when I was pregnant, I would sneeze and pee. Like, that's common. But postpartum, it shouldn't continue, right? Like, once...
Correct. So this is kind of what we tell women. Delivery whether it was a cesarean or a vaginal delivery, your tissues, your pelvic floor muscles are gonna be basically what support your internal organs throughout the pregnancy. So even moms who haven't had a vaginal delivery can have what we call stress urinary incontinence or urine leakage when they sneeze or cough or things like that. That is normal in the first 2 weeks postpartum. After that, it should be progressively getting better and resolving completely. So if you're somebody who you go to your 6-week follow-up with your OB or your midwife and you're still having leakage of urine, whether it be with picking up your baby or coughing or sneezing or exercise, that's not normal at that 6-week mark. It is common, but again, it's not normal. Some other things that we see are pain with intercourse. That is also not considered normal. I feel like a lot of times our first 6-week checkup is like the go ahead and have sex. And, not everybody might be ready at 6 weeks. And if you are, and your tissues are doing okay, then by all means go for it. But, some women might not be ready for intercourse at the 6-week mark. And if it's painful, that's a sign that your tissues are not ready or that there's something going on that needs to be addressed to kind of help your tissues heal a little bit better. The other thing that is sort of normal in the first 2 weeks, but should progressively get better and better and eventually resolve, is a sensation of pelvic heaviness, or they feel like their insides are falling out, right? Well, I've had women be like, it's weird. Ever since I had the baby, if I sit on the toilet or if I bend down to pick up something, I sort of feel like I have a bulge or something's kind of like hanging in my vagina that didn't feel like that before. Again, in the first 2 weeks postpartum, that's common and could be considered normal, but that should totally resolve after the first 2 weeks.
That's so interesting. I wonder, okay, so, and I know that every woman, their vagina is different, the delivery, the pregnancy, everything's super, obviously different.
Yeah.
But is there one or two very basic pelvic floor exercises that you recommend, or is this specifically on, let's do the examination and see?
So, really and truthfully, and I hate, it's such a dismissive answer, but it really truly does vary for each woman. With that being said, in the very beginning phases, so in the first 2 weeks postpartum, we recommend that every woman start trying to sort of do a Kegel. Now, mind you, it's going to feel like radio silence down there because your tissues just underwent the birth process and they're fatigued and things like that. But a lot of times just sort of reconnecting that message from the brain to the pelvic floor can sort of start the healing process. Also, even if you're only getting a little bitty flicker of a contraction, a lot of times that can help to bring blood flow to the area, which can help with the healing as well. The reason that we're careful to just tell women, oh yeah, okay, just go ahead and do a bunch of Kegels, is because if you're somebody who has pelvic floor overactivity or tightness, right, which you could have had that prior to pregnancy and during pregnancy and all that, or if you have tightness related to scar tissue from a tear healing or things like that, you have to be careful that you don't overdo the strengthening, because if tightness already exists there and you're doing all this Kegeling, then over time what's going to happen is the muscle is just going to get really tight and stay really tight, and then it limits its function. So in other words, if it's already really, really tight, when you go to sneeze and you need it to contract really quickly to hold in the urine, it's not going to be able to do that. So a lot of times what we want to find when we're kind of guiding women on how to get back to feeling good and feeling like everything's working properly is a nice balance between Kegel strengthening and then also a lot of stretching and things like that to make sure that we're just getting full mobility of the tissues and also full contractibility of the tissues, if that makes sense. The other thing is the pelvic floor functions in multiple different ways, right? So if we're sneezing or coughing or jumping or doing something rapid, that's going to require us to have a really maximal rapid contraction, okay? But if we're rocking our baby or wearing our baby or exercising or walking or just going about our day-to-day activity, that's more of a submaximal, longer hold kind of contraction. And so we're going to have to rehab our pelvic floor in that way, right? So we're going to have to retrain both of those various different types of contraction. And that's what's really great about the pelvic floor evaluation, is that we can assess all those different things. So we might have a patient who has a really good low load, long duration hold, but can't get that quick activation,
right? Or
vice versa. And so ultimately, if you're having any sort of dysfunction, I really would recommend seeing a pelvic floor PT. And that can we can just do a really thorough exam to ensure that we're figuring out what's going on with your tissue specifically. But I would say that working on the various different types of Kegels, so like quick, let go, quick, let go, quick, let go, or contract, hold for a few seconds, relax, contract, hold for a few seconds, relax. As we use in the clinic, and this seems like a weird analogy, but it actually, something about it clicks in your brain. It's like drinking a drink that's the consistency of a smoothie through your vagina with a straw, if that makes sense.
Yeah.
So it takes a little more suck than just like if you're drinking water or something like that,
yeah.
right? And so we use that cue a lot, because it's not uncommon for, especially after delivery and pregnancy, for women to be like, I have no mental connection with down there. Like, I can't recognize what I'm doing. I feel like I'm trying to activate and nothing's happening. And so that's a lot of our cueing that we do. Some of the stretches that we recommend that are really good to sort of balance out that overactivity or that tightness are simple yoga poses like deep squat, butterfly, pigeon, cat-cow, child's pose. Those are all things that are going to kind of open up the pelvic floor and open up the hips and kind of help the pelvic floor relax. Mm-hmm. And the other thing that we recommend too, that's really easy and really not going to be harmful at all, no matter what stage you are postpartum, is diaphragmatic breathing. And that's like those big belly breaths that people encourage you to take in yoga and things like that. And the reason why that's so helpful for pelvic floor relaxation is that the diaphragm and the pelvic floor move the same way. So when we take a big breath in, the diaphragm and the pelvic floor drop down and lengthen. When we exhale, the diaphragm and the pelvic floor contract and draw up and in. Mm-hmm. So we can use that big belly breath to sort of encourage the pelvic floor to relax. So typically, as long as our clients are getting a good balance of Kegel exercises and relaxation exercises, then things are fine. When you run into problems is if somebody has overactivity and all you're doing is Kegeling, or if somebody has weakness and all you're doing is stretching. So a lot of times it's just going to take a balance.
You got it. With that, something that I heard at one point with the analogy of the pelvic floor, it's almost like if you think about a tissue with all four sides and pulling it up. Correct. Rather than just a Kegel, I guess, because I think that most women, and now diving in deeper to this vagina world and, pelvic world and woman world, most women have never really looked at their vagina. No. Which, they're doing themselves a disservice, because they should see it and know what's going on down. Like,
yes.
And I remember after I had my little one, I had an episiotomy, and I had to look, because I was like, I need to see because it feels like a complete catastrophe. Different. So I need to see what's going on.
Yeah. Yeah.
And, but it's just funny, because the more that I talk with them, they're like, yeah, I never look down there. And I'm like, why wouldn't you have to look down there?
Yeah. It's crazy. We even get patients, and I'm saying this for education purposes, not to make fun of anybody, but we get women who don't even realize that the urethra, where urine comes out, and the vaginal opening are two different holes. Like, we have some women that think urine is the same, or like urine comes out of the same place that you have sex. And so, yes, unfortunately, there's like not a lot of body autonomy. There's not a lot of body awareness. I have patients who are like, well, wait, you use the word vulva, but you're looking at my vagina. And so they don't even realize the difference between the vulva and the vagina. And so, yes, you're right. Not a lot of women look down there, nor are they aware of the anatomy down there. So
I need to include a little map here. I'll do a little pop-up map so women can see what's going on. But it's an interesting thing because it's I have a girlfriend who I had come on here and she did a at-home birth and had a midwife and she had something that she said is like kind of rare, which was a labia tear. And
yeah.
And we didn't even have a chance to get into it, but I was thinking after the fact, how does that even like
occur?
Well, yeah, how does it occur? But also how does it heal and how does that affect like, sex after and orgasms and all that stuff? Because that goes.
So it's interesting. I can give firsthand experience on that because I also had the same
Wow.
situation with my second. So both of my deliveries I had in a hospital, unmedicated. My first one, I had to be induced. She was late. It was a beautiful delivery. I hardly tore. Everything was fine. My second, I had what they call precipitous labor, which means like just really, really, really rapid labor. So I started having contractions at 5 a.m. By 7:36 a.m. he was born.
Wow.
Yeah. And so I don't know if this would have happened anyway, or if this is because he came so quickly, but he was basically face first. So when babies are delivered vaginally, their face should actually be facing your rectum. And that allows for their skull to kind of drop under your pubic bone and come out. But sometimes babies don't turn and they'll come out face first. And so you're more likely to have a labia tear if your baby is face first, if it's either a really sort of rapid pushing phase, which is what happened to me, or sometimes it's just positioning and how they come out. So basically, sorry, I'm plugging with.
It's okay.
Can you hear me still?
Yeah.
Yeah. Okay. So it's interesting because it depends on the severity of the labial tear as to whether or not they're going to stitch that. Every once in a while, they'll get what they call brush burns. So you'll get like a teeny tiny little tear just in the initial skin right there on the labia, and those typically heal on their own and don't require any stitching. Occasionally, you can get tears that go all the way up into the urethral tissues or the clitoral tissues, and so when you have tears like that, they're oftentimes going to require stitching, but then they're often also going to affect urinary function and sexual function.
Yeah.
So, from a standpoint, we'll start with sexual function. From a standpoint of sexual function, we have, and I wish I meant to grab my model and I forgot. But anyway, you have your clitoral body, and then over your clitoral body is what they call the clitoral hood. And it's just tissue that covers the clitoral body so that when we're going about our business, it's covered, right?
Right.
But that tissue needs to move kind of back and forth so that we can be aroused, we can orgasm, all those sorts of things. If the tear extends into the clitoral hood or into the clitoral body, a lot of times as it heals, it can get scar tissue or tissue restriction. And so what will happen is it can limit the movement of that clitoral hood, but it can also limit sensation. So a lot of women that I've had, and this was my personal experience. So my labial tear kind of went all the way up the right side and like into my clitoral body.
Oh.
Yeah. Yeah. And so had to have a lot of stitching. And it was interesting because it started out as numbness, right? Like I just felt nothing basically for the longest time. And then it was interesting because as my sensations start to come back, it was like hypersensitive. It was almost as if like anything touched it. I was like, oh, that's too much. And it wasn't, I hate to call it pain because that wasn't really the right word. It was more just like, it almost felt like it was raw and like anything touching it was just really sensitive. And I've actually had a lot of patients complain of that as well. And that's not uncommon when you have like nerve healing and things like that. It'll start out kind of numb and then it's got what we call abnormal sensation, right? So touch that should be good touch or soft touch or just normal touch will feel painful. And that can affect intercourse, right? Like,
of course.
It can either make you avoidant of intercourse. It can make you unable to orgasm, unable to be aroused. And a lot of women, this can affect, understandably, it can affect them emotionally, like I know I went through this period where I was like, what is wrong with me? Like, I don't even want to have sex anymore because I'm broken and like I can't even have an orgasm. And then oftentimes we have really, I mean, we're blessed in our clinic that most of the partners that we get that come in are super supportive and wonderful partners. And so they're usually down to help or be educated on kind of whatever they can do to help their partner. But I know a lot of women feel like, I don't even want to waste time. Like my partner's going to think I'm not into this and all that kind of stuff. And so the good news is there's a lot you can do to help the tissue heal, or a lot of a therapist can do to help the tissue heal. Some of that might require kind of daily moisture to the tissue. So something as simple as vitamin E oil to the tissue, or something as significant as like topical estrogen cream that your OBGYN might prescribe, just depending on how the tissue's healing. The other thing that we can do is a lot of scar tissue mobilization to the area, believe it or not. So we'll do what we call like labial skin rolling, which kind of looks, if I can like show you on my hand. So if this is my labia, we're just kind of taking our thumb and our index finger and just kind of rolling it gently, not squeezing hard. It shouldn't be painful. But our goal there is to sort of bring blood flow to the area, kind of help the area start to heal, reduce any sort of tissue restriction that they're having, and also kind of desensitize the area so that they're not having numbness or hypersensitivity, and so that their sensation is normal, if you will. The other thing that's really important with tears like that are checking the surrounding tissue. And that's honestly with a labial tear or a perineal tear, right? We always want to check the surrounding connective tissue, like the inner thighs, the lower abdomen, the butt muscles. Believe it or not, we hold a lot of tension in our pelvic floor, especially when we've had trauma to the area. And so if you've had a tear or painful sex or any sort of trauma to the area, we have a tendency to sort of like clench all those muscles that surround the pelvic floor. And a lot of times that can feed into some of the issues that directly affect the vulvar tissues or the vaginal tissues or the pelvic floor muscles. So we always assess all those external tissues as well, just to make sure that if there's any restriction there, we're addressing that also. The other thing in regards to your labial tearing is that can affect urinary function, right? So again, it can be something as minute as a tear in the labia right near the urethral body, or it can go all the way into the urethra or the urethral body, which in that case, they could have everything from difficulty holding their urine, difficulty initiating the flow of urine when they sit, difficulty sort of sensing if they've finished urinating or if they still have to go some. They could have some leakage after emptying, like so they sit on the toilet, they pee, they stand up and a little bit leaks out. But the same way, we would address that the same way by like working on that connective tissue and making sure that scar is healing well, and then kind of retraining those muscles like, okay, this is how I want you to work, when I want you to hold the urine in, and things like that.
Yeah. It makes sense though that it's almost like when you don't use it, you lose it, right? So like that area down there has so much blood flow that theoretically, if you're not using it and orgasming or having sex or whatever, then it's just gonna get rusty and in more pain, and it will be harder to move forward. It kind of seems like.
Right. Well, and there's this really wonderful book called. There's a couple wonderful books. One is called "Come as You Are."
Oh.
And the other one is "The Body Keeps the Score." Right.
Okay.
And I really like, especially "The Body Keeps the Score" because it talks a lot about the emotional and psychological aspects of pelvic health. Right. And I think it's sort of a slippery slope because you don't want to say like, oh, well, that's an emotional component, because I think a lot of women already feel dismissed and quote unquote crazy. And that's by no means what this book means, right? Like the pain and the symptoms that these women are experiencing are very real and very valid. But there's a huge psychological and emotional component to our pelvic floor and how it functions. And we can hold an extreme amount of tension in our pelvic floor. I joke about it, but I feel like right after the pandemic, I got tons of moms that were like, I'm peeing on myself all the time now. And I wasn't doing that before. And I don't know why, but like I have all these symptoms now. And, this is just guessing, or my just thoughts on this, but I feel like, we've all been so stressed because of the pandemic that it would not shock me. And I've found clinically that most of my patients are just really holding a lot of tension in those muscle groups. And sometimes we don't even notice it. The same way that you might hold tension in your shoulders, and every once in a while you're kind of like, man, my shoulder's killing me. But you don't really realize until somebody gets in there and gives you a massage, like, oh my gosh, I really was like holding a lot in there. And then you add to the fact that most of us who have had babies have had some form of pelvic trauma. Like, even if you had this beautiful delivery and you didn't tear, your tissue still underwent this massive change. And so I don't think we allow enough healing time to those tissues, and subsequently we get a lot of tension after.
Yeah. Speaking of the tearing, not tearing, because I feel like there's this, and I don't know what it is. So you would know the truth behind this. To tear or to be cut, because they say to be cut is better than to rip, but what's the professional say?
So according to a lot of the most recent research, letting your body tear on its own, if it's going to tear, is a little bit more beneficial. And the only reason for that is that if they have to do an episiotomy, it's automatically a grade 2 tear. It's possible that you might tear and only have a grade 1 tear. And so ultimately our whole goal with childbirth is to have as little trauma to the tissues as possible, right? And so, I definitely think that, and the research supports this, that there are situations in which episiotomies are necessary, right? Like if there's a medical emergency with the baby, or if, there's a medical emergency with the mom, or other varying situations. But for the most part, most of the current research supports more kind of letting you tear on your own versus episiotomy.
Yeah, it seems like the more that I'm diving in this, the more it's going back to the holistic midwives, this let your body do what it's made to do. Just, it will, your body will release these hormones. It will be fine.
Yeah. And it's interesting that you bring up, like, let your body do what it's going to do. I feel like there's a lot of coached pushing out there. And what I mean by that is like, okay, hold your breath and push, right? And really, I think what coached pushing has done has kind of made pushing this way more aggressive than it needs to be, right? Believe it or not, the pushing doesn't even really need to be that intense or that aggressive. And the reason for that is that our uterus is doing the work to expel the baby. They actually call it the fetal ejection reflex. But basically, all those uterine contractions that you're having are to push the baby out, right? And so we get a lot of situations where either the patient is pushing when they're not having a contraction, or they're holding their breath and pushing, or they're pushing for too long, or they're pushing really, really, really aggressively. And all of those situations just put a lot of unwanted stress on our tissues. So a lot of what we encourage our patients to do, whether they're medicated or unmedicated, is only push when you're having a contraction. That way you ensure you're allowing your uterus to do the vast majority of the work. And you're not kind of over pushing with your pelvic floor. Make sure you're exhaling as you push. So breath holding is not great for many reasons. One, it can cause what's called like a Valsalva response, where essentially you're like increasing your pressure, increasing your heart rate. It can make people have what's called a vasovagal response, which is where you pass out or things like that. Which is not ideal. The other thing is that increasing all that pressure in our abdomen puts a ton of stress on our pelvic floor muscles. And for women who are at risk of diastasis recti, it can put you at higher risk for that. So we encourage women to exhale as they're pushing. Now, in our childbirth prep courses, we teach it like a, right? Realistically, when you're in the midst of labor, it's probably not going to look that pretty, right? It's going to be more of like a guttural moan or a yelling or things like that. And that's okay. Our whole goal here, though, is to make sure we're not breath holding, so that we're not putting all that stress on our tissues, and to make sure that we are pushing as effectively as possible without over pushing with our pelvic floor, if that makes sense.
Definitely. Well, and I think that the exhale and the effort only makes sense because it's exactly what you're doing when you work out, right? Like you exhale on the effort. And I know like I was in fitness for a very long time, and, you know, people come to class, you're teaching personal, privates, whatever, and people don't know when to breathe.
No, they don't.
Like they forget to breathe, for one.
Correct.
Or they are breathing on the wrong part of the motion. So it makes sense, exhale on the effort.
Yeah, absolutely.
Okay, so my other question along those same points, the perineal massage, to do or not to do?
So the really old research done from years ago looked at perineal massage in the delivery room, like while you're crowning, and that showed to have little to no benefit, right? Which makes sense. You're not going to like train for a marathon at the starting line, right? But the more recent research that's sort of in the process of being done, and they've gotten some initial sort of findings back, but they haven't published it yet, is showing that perineal massage, when done from like 34 to 35 weeks of pregnancy on, about 2 to 3 times a week, has actually shown to reduce the likelihood of tearing and kind of improve the mobility of the tissues. So my answer is always yes, because it can't guarantee 100% that you're not going to tear, but it's not going to hurt. And there's research there to support it.
I definitely see that. And I get it because, you know, and I'm not into it, but there's these crazy pornos, right? Where there's all sorts of things going up there. And obviously these women they're in pleasure or they've learned how to relax those muscles and or they've done enough to really stretch it out.
Yeah.
So it makes you wonder, like, why? Because there are a lot of contradictions on stretch it, massage it, don't. And it's like, well, it only makes sense that you should.
Yeah. Well, and I think too, a lot of times we get so caught up as a society in looking at the pelvic floor and the vagina as like either a sex organ or a reproductive organ, that a lot of times we forget that it's a musculoskeletal system, and it responds very similarly to other musculoskeletal systems. The difference is that it also helps with things like peeing and pooping and sexual function. So yes, in some ways it's different than other musculoskeletal systems in the body, but it very much is still a musculoskeletal system and responds very similarly to other muscles in our body. And the reason why people are always like, well, what's the reason? What's so important about perineal massage, or why would we do that? And the main reason is the perineum is the area that's going to sustain the most amount of tension or stretching during delivery, because that's right where the baby's crowning. There's a lot that connects into there. I mean, your pelvic floor muscles connect into the perineum, your external anal sphincter, your glutes, your inner thighs. There's just a lot that connects at that one little area. And most people, it's not like our perineum is huge. I mean, it's like little bitty, right? And so there's not a lot of like room for it to stretch. And so just the more prepared we can have our tissues, the better. Now, that doesn't guarantee that you're not going to tear, right? I mean, I've had women that did all the right things and still tore. And then I've had other women who were like, yeah, I didn't do anything to prepare for this delivery and I didn't tear at all, but now I have this or whatever. So some of that is just genetics, like what is your connective tissue like genetically? Some of that is other factors, like what do you do for exercise? What is your, your sexual and not sexual, gynecological history. So like, have you had other traumas in the area? So it depends on a lot, but by and large, I think the research supports that perineal massage can be beneficial. So why not? This is the way I look at it.
Yeah. I mean, no harm, no foul.
Yeah.
What do you have any input or kind of going back to us, to women being a little more familiar with their parts, their lady parts. When it comes to coming, when it comes to it, orgasming, do you have any suggestions with like, because I know on your blog, the blog, there's like and I'll include the website and all this good stuff, but there's like a ton of different things on there. I don't remember if I saw anything about orgasming and or toys or anything like this, because I feel like that's a huge.
Yeah, so we have a running list of blog topics, so we'll have to add all this to the list. But yeah, I mean, I think everybody's different in terms of like what they like and what kind of turns them on. What I will say is that similarly to having your tissues being able to function by holding in urine and things like that, sexual function is the same, right? So there's 3 layers of the pelvic floor, and I'm really upset with myself that I don't have my model, but the very first layer is like right at the vaginal opening. So like literally if you stick your finger in, you're like 1 knuckle in, and that's the superficial layer, okay? That layer controls orgasm, arousal, lubrication, opening and closing of the urethra, opening and closing of the rectum, all those things, okay? And then you've got your deeper layer, which that's more of our like postural layer that helps support our organs and the baby and stuff when we're pregnant. So similarly to holding in urine and fecal matter and things like that, if we have overactivity in that superficial layer, what needs to happen for us to orgasm is that layer has to be able to contract, relax, contract, relax, contract, relax. Mm-hmm. If there's tightness or weakness in that layer, right, that's not going to be as effective, which is going to make it more difficult for you to orgasm. Mm-hmm. We also have some women who, believe it or not, have pain with orgasm.
Is it because they're holding their tightness there? Is that what it is?
Typically. So basically what a lot of times what happens with that is they might not have pain with intercourse itself. So they might not have pain with penetration or anything like that. But once they orgasm, they have a lot of pain. And a lot of times, yes, that's because there's really significant tightness of that superficial layer. And so when you orgasm, that's basically like maximal rapid contraction of that layer. And so they're essentially getting like a Charlie horse, if you will.
Oh my gosh, that's horrible. How?
Yeah, it's awful. And the other thing that is really, I think, relevant for our postpartum moms, especially if they're nursing or breastfeeding, is that when we're nursing or breastfeeding, our estrogen drops, okay? And when our estrogen drops, our tissues are not as well hydrated as they should be. They're not kind of as plump as they should be. Estrogen is what keeps our vulvar tissues nice and healthy and plump and lubricated and things like that. So if our tissues are dry and a little bit frail and the friction from intercourse is causing pain, then we're going to guard some more and tighten up more, and then it's going to be even more difficult. So what I tell all of my postpartum moms is lather on as much lube as you can, and then when you think there's no possible way you can put any more lube on there, put some more, right? And again, like we mentioned with the labial tears, they might have such significant dryness that they might need some topical or they might need vitamin E oil to their tissues daily. The other thing I will tell you is all these like fancy lubes that have like tingly or warming or all these things, those are really not great for our vulvar tissues, right? It's going to irritate our vulvar tissues. It can make our vulvar tissues dry. Over time, it can cause pain. So in terms of keeping our vulvar tissues healthy for sex, always use a water-based, glycerin-free, paraben-free, scent-free lube. And that way it's not going to irritate your tissues. And also that way it's going to hydrate your tissues the way you want. The other thing I will say too is that if you are nursing or pumping or early postpartum, and so that hydration to the tissues hasn't quite yet gotten back to where it should be, foreplay is always a great way to bring good blood flow to that superficial layer. I know it's hard when we have new babies to most of us are just trying to get it in when we can get it in, but if you can take a little extra time, I think a couple reasons why that's great. One, it's going to bring some really great blood flow to the area. Two, A lot of times it sort of eases you into it and takes away some of the anxiety, like, oh gosh, this is going to hurt. Like, I'm nervous about any sort of penetrative intercourse. And so I think it can kind of make the woman a little bit more comfortable, be like, oh, that touch actually feels good and not painful. And it helps you relax a little more, which over time is going to be good because we want those muscles nice and relaxed for the duration of intercourse, right? The other thing is that, and I always tell patients this, like, there's no rush. If you're postpartum, even if you get the go ahead from your physician to try intercourse, if you try it and it's painful, my advice would be to wait. Because as I mentioned, we hold a lot of tension in our pelvic floor. So every painful experience is going to most likely increase any of that pelvic tension, increase any of that pelvic guarding. And so then the next time you're already apprehensive about it hurting. So ideally, we want you to have what I call like positive pelvic experiences, right? So we want you to have enjoyable touch. So let's say maybe you and your partner try penetrative intercourse and it's really painful, but you can tolerate foreplay or oral. That's a great place to start because then it's going to get you comfortable with touch again. You're going to have a positive experience, and it makes you less apprehensive about the next experience, if that makes sense.
Definitely. Speaking about those parts those parts down there specifically, what is, because I remember, and I don't know exactly, but generally, and you'll be able to kind of pick up where I'm at with this. So when you are very pregnant, they'll swipe the cervix to induce your labor or something?
Like a membrane sweep.
Yes. Yeah.
So they'll do a membrane sweep. Everybody has a mucus plug, right? And what happens, like for labor to start, is you have to lose your mucus plug. The baby has to be fully effaced or like right up against your cervix. And then what happens is your cervix just slowly starts dilating. For people who either are not losing their mucus plug or their cervix is having a really hard time dilating, they can get in there and do and physical therapists don't do this. This would be like your midwife or your OB. But they can get in there and do what's called a membrane sweep, where they're basically like sweeping that membrane around your cervix to try to help promote it dilating. It's usually pretty uncomfortable. I've had patients be like, wow, that I was not expecting that to hurt. But yeah, it's usually pretty uncomfortable. And I've had some patients who have been like a week and a half late, gotten a membrane sweep, and it still didn't help. And then I've had other patients who their OB was like, well, you're like 39 weeks. Let's just do a membrane sweep. And then they went into labor. So it really is just sort of dependent on a lot of variables. But yeah, they can do that.
Very interesting. I had a girl on and she was saying that she did it because like she did it herself.
Oh, okay.
And yeah, I don't know why or what happened, but it was just interesting because I'm like, I remember they never mentioned it to me. And I think my sister was like, because I went to almost 42 weeks.
Okay.
And my sister was like, well, ask. And I went in and I couldn't remember. And then obviously I still can't remember the name of it, membrane sweep. And but yeah, anyhow, that is an option for ladies listening.
Yes. Yeah, that is an option. And, like, I always try to tell patients this. If you're someone who is really wanting an unmedicated delivery, like let's say your goal is to go completely natural, no epidural, or maybe you're birthing at home or something like that, and you're going into the 41-week, the 42-week realm, there are ways to induce labor without the use of Pitocin. Because I know like Pitocin does make the contractions a lot more intense and it makes it a lot harder to go unmedicated. And so there are ways that you can induce labor without Pitocin. A membrane sweep is one of them. There are other things called Cervidil or Cytotec, which are suppositories that they'll put in the hospital or at the birthing center that are supposed to soften or ripen your cervix and help it kind of make it easier for it to dilate. There's also what they call a Foley balloon. So they can basically insert this little catheter with a balloon that kind of manually over time opens up your cervix. So there are options. And then, for patients who are going unmedicated, movement is great, right? Like, so the longer you can be up, moving around, kind of getting into some of those positions that are going to open up that pelvic inlet and open up that pelvic outlet to allow that baby to drop down. Those are some other really great natural ways to try to induce labor and kind of get the ball rolling.
And the ball, I think, is very, very helpful.
Oh, yeah. Yeah. The ball is wonderful, especially for people who find that movement is a really good means of pain management for them, right? Mm-hmm. So like if you're in a lot of pain, because ultimately what I tell all my patients is ultimately we want you as relaxed as possible, right? Because the more relaxed you are, the more relaxed your pelvic floor is, and the easier time you're going to have with the pushing. So if you're somebody who your pain management technique is movement, the ball is great for that. I mean, for so many reasons. Mm-hmm. So yeah, I mean, I think that's a great option.
Awesome. And maybe one other thing before we wrap up, common, I don't know, whatever you see that you think is, important to share for women.
So I think my biggest other thing, and this is like kind of my little personal soapbox, and kind of like most of the clientele that I see in our clinic. So I'm a CrossFitter. I'm a former distance runner turned CrossFitter. And I CrossFitted through both of my pregnancies, modified, of course. And I unknowingly, because I wasn't in pelvic health at the time, I was still in orthopedics. I unknowingly went back to CrossFit way too soon after my second was born, and subsequently did some damage to my tissues. And so I think the biggest thing, and I'll touch on a couple things with that. One, we as a society have this term bounce back or get back to normal, which I hate because, your tissue is not ever going to be the same. It doesn't mean that it's not going to be fully functional and totally healthy, but it's not ever going to be the same, and that's okay. Two, it just took you 10 months to grow this tiny human. It's normal for you not to be back into the gym right away, right? And this is especially true for women who are engaging in high-level activity like CrossFit, Orange Theory, running, hiking, a lot of those activities that are going to be really demanding on our core and our pelvic floor. And so the most recent research, and there's a couple of different articles out there, both are in the British Journal of Medicine. One of them looks at for how long after pregnancy and delivery could a woman potentially experience difficulty or symptoms with her pelvic floor. Now that could be urinary incontinence, pain with sex, prolapse, diastasis recti, a multitude of things that they looked at. And the research showed 18 months.
Wow.
So that means that our tissues are still undergoing healing and undergoing change for 18 months after we have the baby. Then you have to think if you get pregnant again within that 18-month period, then that's even longer. Mm-hmm. Okay. So that doesn't mean that you can't get back to doing everything that you want to do. It just means that you're going to have to do so at the appropriate pace, at the appropriate time, and with the appropriate modifications. The second really important article shows that the tissues really aren't ready to sustain high-level activity like running, powerlifting, crossfitting, Orange Theory, things like that, until at least 12 weeks postpartum. And if you think about it, like in my orthopedic background brain, I'm like, well, that would be the case for like an ACL repair or a shoulder surgery or things like that. So it's like blows my mind that makes sense to us for other connective tissues, but not for our pelvic floor. So just know that if you're wanting to get back to things like that, you really need to not be like going after it until 12 weeks. Now, that doesn't mean you can't be in the gym at all. It just means that you need to do so with modification and very, very, very gradually. And that's I'll just give my plug. That's a big part of what I do, right? So like a lot of the clientele that I'm seeing for childbirth prep, and then I'm seeing them again after to kind of get them back into the CrossFit gym or get them back to running or things like that. And a lot of we offer virtual sessions too. So a lot of the virtual sessions I'm doing are kind of like virtual coaching on like, okay, now you're okay to do this, and now you're okay to do that, and let's progress to this sort of thing. So that's my other big takeaway is give yourself grace. both emotional grace and physical grace. It took a long time for your body to grow that human, and you have undergone a massive change, and it's going to take some time to get back to feeling like yourself, and that's normal and that's okay.
Yeah, it's an interesting that postpartum period, because it's like also in the CrossFit scene, for like I am also, so going back to box jumps, double unders, like the high impact things.
Yeah.
It was such a mental, like it was just very mental, because you just take this time off and you think like, okay, I was doing, so many things so easily.
Correct.
But it's like, actually, I'm going to step down.
Yeah.
And I'll jump up and I'll step down. I'm not going to rebound. I'm just going to step. And I think that it really takes, which for me, and I think that a lot of women that I've met recently with COVID happening, it's been really nice to not actually go to a gym, because there's no competition. It's just you and yourself. And I think for me, it's been a huge blessing, because I am competitive. So I'll go and I'm like, and I probably wouldn't have been able to control myself. So it's actually been amazing to just work out by myself, not have to, prove anything, just do my singles or, whatever.
Yeah. And I think it's really hard too for a lot of women who are in that environment, because oftentimes we have to modify even more postpartum than we did during pregnancy. So we're like, wait, I was doing this when I was pregnant, fine, but I can't do it now. And so I find that a lot. I find that we actually need to modify more postpartum than we do during pregnancy for a lot of these like CrossFit style workouts. And that's okay. And this is like my last little thing is, I know for a lot of people who are into sort of group fitness, the community is a big part of why they're drawn to that type of activity. And so I always tell patients, if you can assure me that you can go to your gym and still engage with all your friends or people, and COVID times is different, but if you can ensure to me that you can go and just do these little physical therapy exercises that I'm giving you, but not feel compelled to like get in the Metcon or whatever, I'm okay with you going back to the gym. If you're somebody who's really going to want to compete and push yourself and things like that, you need to do all this stuff at home until you're ready to go in and be like, okay, I'm okay modifying, and that's fine.
Totally. It is, as much as that community is wonderful, in this little phase, these few months postpartum, you really gotta, just do it by yourself or whatever. Definitely. And it is, it's funny because it's so true how like literally up until I had my little one, I was doing everything.
Yep.
Box jumps, double unders, rope climb, whatever.
Yep.
And then postpartum, no.
You're like, oh,
yeah,
that's not happening.
So, but that's why I think it's so interesting is like society has it
flip-flopped.
Yeah. And I don't understand. Only when you get there do you realize, oh, now the journey's starting. Now it's hard. Now this is when. So I always tell, women that are having babies or that are pregnant that like, because they always say, oh, I'm almost at the finish line. I'm always going to, and I'm like,
and you're like, no, you're at the starting line.
You're just starting. So make sure you're working out, make sure you're taking care of yourself throughout that whole pregnancy, lift, do things to strengthen yourself, because you're going to want that strength.
Oh yeah. Absolutely.
It's crazy.
Yeah.
She's like, Mom, someone's home. Okay, so website, social media, anything else you want to share?
So website is thevaginawhisperer.com. That has access to, we have some online courses that you can take. Some are childbirth prep, some are postpartum recovery, some are related to diastasis recti recovery. So we got some great online courses. We got some great blog posts on there. We also have the signups for in-person sessions if you're local to New Orleans. If you're non-local, we have virtual consultations. If you'd like a virtual consultation specifically for like CrossFit guidance, Melissa Stendhal is one of our online PT therapists who does a lot of that. And then I can do that too. I don't have online sessions set up right now just because I'm primarily in the clinic, but I can do online sessions easily. You just have to email me. My email is emily@nolapelvichealth.com.
Cool.
My coworker and mentor is Sarah at nolapelvichealth.com. She is the Vagina Whisperer on Instagram, and I am Emmy Mac PT, EMMIEMAC PT.
Perfect.
My Instagram has been a little lacking lately because my husband is on a year-long military deployment and I am like in survival mode. But now that we're past the holidays, I'm like feeling energized and better. So I should be getting some more content up
Cool.
as we go. So
awesome.
Yeah.
Well, thank you for your time. And
thank you so much for having me.
My
and thank
absolute
you for
pleasure.
doing this.
Of course.
This is how we get to the point where it is talked about and it is understood, is that people like you do things like this and make it known. So thank you.
Thank you. But seriously, it was such a pleasure to talk to you.
Yeah, it was a pleasure talking to you too.